So yeah, anybody have any questions or thoughts about anything? We're doing endocrinology and neurology today. I know we kind of breezed through eyes, ears, throat, and respiratory, but respiratory is a lot of that we covered in airway. That should have been more like of a review. So any thoughts or questions? Few items of note. I need you all to actually do your assignments. I have like 7 people who didn't hand anything in on yesterday. Welcome to Monday. Things are due on Sunday. Matt, please don't crash as you enthusiastically wave that you didn't do your homework. Yeah. And you guys are required to respond to other people's discussion board posts. There's been also a little of a fall off on the consistency in that, so please pick those 2 things back up. I know this class is long. I know it is trying, both mentally, emotionally, physically, and psychologically, where you kind of want to just jump off of a bridge. Please don't. Don't recommend. But I just stay focused. You have 2 modules left, 3 tests. I know you're getting you guys back into skills labs a little bit. Hopefully that will be a little more entertaining, because it's kind of a little more stimulating. But please stay focused with homework. So yeah. Anything else? Sure. I just got to it. So, I thought you guys do a really good job of the discussion posts. I just want to see more discussion between like classmates. I know it's kind of like you're all talking about more or less the same thing. But I do know some people find some information that different than other people. You don't necessarily have to agree with stuff. I think the Wednesdays was the using a pediatric BVM for lung protective. I thought a lot of you did a really fantastic job. You really went in depth, really kind of discussed it. If you don't agree with it, you're allowed to not agree with it, but like support it. Be like, I don't think that's enough oxygen. I think that honestly it's a really good idea, especially if you're working with like in the city and you're like, hey, firefighter, use this, I need you to ventilate while you're going downstairs, or maybe because even as very well-trained professionals, you can still get over enthusiastic on a BVM. And if you think about the size of an adult BVM, that's a lot more air than human lungs can actually handle. So you can potentially cause a lot of damage if you get a little over enthusiastic. If you're doing it like one-handed and crushing it against your leg, which I think everybody has done at one point or another. Using a pediatric BVM is, I think, a little bit easier to handle and a little less likely to cause damage. I think that there needs to be maybe a few more studies on it just to kind of determine how effective it is, because I did see 1 or 2 that were like mixed thoughts on lung protective ventilation, where they were like, we don't really think it does much. But most of the studies were like, no, this is a good thing. I definitely don't think a ventilator on every ambulance is cost effective. It's too much money. I think if we're going to put a mechanical item on the truck, it should be an IV pump. Because then you can't mess up your dopamine or lidocaine or norepinephrine drips. It just makes it a little better, and it's consistent, because you hit a bump and you can end up with more dopamine, because it knocks the drips out. Ventilator, if we can do research on whether or not that pediatric BVM is efficient, and it might not be sufficient for everyone, like there might be a larger obese individual who's got just too much weight on their chest for that amount of air to give you adequate chest rise. But I think it would prevent a lot of over enthusiasm when it comes to ventilating patients. Because you think about it, you get this big old bag and you kind of like, you get excited, right? You kind of start squeezing and you're really looking for chest rise, but you're really going a lot more enthusiastically than you might need to. Because you kind of think in your head, especially like you go think back to like EMT class, right? When they start like, all right, you're gonna ventilate, right? All right, yeah, cool, I'm gonna ventilate, and you have this big old balloon, and you're like, I'm gonna squeeze this whole thing. They're like, no, you're just gonna. And you're like, what do you mean just? And I think it really does help in preventing firefighter problems for anyone who's in the city and is like, I know what you mean. Those guys get way too excited. Way too excited. You're welcome. Exactly, like, and then yeah, and then has anyone ever been sprayed with a geyser of vomit when doing BLS ventilations? Because you're like you're a little too enthusiastic, and you go yeah, and then it's just like, huh? And you're like, oh no, oh, this is just disgusting now. Like nobody wants to deal with that. This is gross. Sometimes you're just not fast enough, though. It's just like then you yell at the probie that they didn't do it, like they should have been on the airway, right? You're like, guys, what are you doing? But good, very good though. Let's have more of these conversations on the discussion board. You don't have to be super prim and proper, I promise. All right. Any other thoughts, questions before we whatchamacallit? Move on to, we're gonna do endocrinology. Actually, let's do neurology first, so that like I can end with like good slides that don't make me sad, because the saddest. See, look how boring these slides are. Why is it so tiny? Stand by as I do it. Like I struggle with this, clearly. Come on. There we go. Donde? What is going on here? There we go. Kind of. What are we doing? Hold on. I continue to struggle. That is exactly what it is, right? I think it's absolutely awful. Which is why I spent like, what was it? Were you guys at POC 27? I did all POC 25. I made brand new slides for them, like start to finish. Like they got all brand new slides, and it was so much better. I can't make this super big and still actually give you the recording, so I apologize. It's gonna be a little tiny, but we're gonna kind of power through it because again, there are like 3 topics in neurology that are very important: strokes, seizures, and like the other, right? Like they kind of like group together and like other items that are troublesome that we deal with. But for the most part, we're dealing, right, as EMS, we're dealing with strokes, we're dealing with seizures. Brief review, right? You have your central nervous system, which is your brain and spine, and then you have your peripheral nervous system, which is like everything else. You also have cranial nerves. The important and kind of interesting thing about the cranial nerves is they come directly out of your brain and into like your head and neck. And then you also have the vagus nerve, which comes directly out of your brain and goes directly into your butt, okay? Like goes straight down, but it's not affected, it's not like a part of your spinal cord, okay? So that, and the vagus nerve also, influences your heart, if you and your GI system, et cetera, but it is not in any way, shape, or form attached to the spinal cord itself. Which means if you have a patient with a spinal cord injury, the vagus nerve is still potentially intact, provided, it wasn't severed due to a stab wound or, shooting or something else like that. As long as, nothing Yeah, go ahead. Mm-hmm. Yes, I'm not sure. Now I gotta go look into this. Stand by. I'm gonna have to Google that. I'll Google it and get back to you. You're all gonna get like a flight. Uh, there you go. There's your way better answer than what I can give you. That's pretty cool though. All right. So now, in addition to your cranial nerves, you also have spinal nerves. If you've ever looked at the picture of the dermatomes, right, and you have like those like tracks around the body, that is the what the spinal nerves do, right? They come directly out from in between your vertebrae. They wrap around the body, and depending on where, like if you do have a spinal injury, that is sort of the areas where you lose innervation, right? So we know that like T12 is like the umbilical area, T1 is nipples, right? So going from there, like that's kind of the idea. There you go. There's a really super useful. It's not that useful. Picture. So kind of going back to A&P really quick, right? You have your cells of the nervous system, which are your neurons. The neuroglia is the connective tissue. If you're having nerve pain, it's neuralgia, not to be confused with neuroglia. It's where the L is, the positioning of that L. So neurons are kind of interesting little creatures where they will either have a very long dendrite or a very long axon, depending on if they are a sensory or a motor cell. Okay, so if they're a sensory cell, they have a very long dendrite. The very long axon, because it's coming from the flip that very long dendrite, because it's getting information from your periphery and bringing it back up. If it's a muscle cell, it has a very short dendrite and a very long axon, because think of reflexes. It wants to be able to get that information, that sensory information from the skin to the muscle very quickly so that you can pull away. Okay, so it's very short and it moves very quickly. That's really the most essential information that you're going to need in regards to what the cells of the nervous system are. The sheath is called the oh my goodness, I'm having a total blank. Thank you, the myelin sheath. Thank you. Wow. See, this is what I talk about. We're having a neurological issue. You're having a tiny stroke. It's called the myelin. So there's certain disease processes like ALS, right, where the myelin sheath starts getting broken down. Yeah. Yeah. A little bit. So the gray matter in their brain is made of the same stuff as the myelin sheath. It's like this fat. So basically, what happens is in the brain, it's either like Alzheimer's is kind of characterized by protein deposits that are not supposed to be there. Dementia is a deterioration of the brain as a whole. So it's similar. They would say dementia is similar, where that the fatty sheath is deteriorating, so you're losing brain mass. Alzheimer's is a little different, where you're adding protein to the brain in spots where it's not supposed to be. Say that again. That's Parkinson's. Yeah. So if you think of the myelin sheath as sort of like if you take an extension cord and that like orange part of the extension cord, and then you have like the metal wire going through, if you start exposing the metal wire that's inside, it's not going to necessarily, not only will it not necessarily transfer the electrical stimulation as well, but you also might have issues where it starts stimulating other things, right? And that's where maybe when you have people who have like that paresthesia, right? They have those pins and needles and like phantom sensations that aren't otherwise there. Neurons are variously classified depending on what they do. So sensory neurons obviously give you sensory information, while motor neurons give you information to your muscles in order to move. That's really about that. So nothing too wild. Moving on. Hold on. There we go. The electrical transmission of a nerve is very, very similar to how we have the electrical transmission in the heart, okay? So same concept where you have potassium on the inside and sodium on the outside. In order to move the electrical transmission of the neuron down the line, that the nerve needs to be depolarized. Same kind of concept. There's a movement of electrolytes back and forth. Whereas cardiac cells are really influenced by potassium and calcium, because they also need to have the muscular transaction, right, where they contract. Nerves are much more influenced by sodium. So if you have patients who have sodium derangements, you might see them having issues with nerves. Like they might be very flaccid because their nerves are not sending messages appropriately, or they might be hyper tense because they are sending too many nerves. So sodium is very important in the nervous system in terms of the symptomology. That's the word I was looking for. So we talked about the myelin sheath already, right? So if there's no myelin sheath, you're going to end up with that like transmission that you do in like a left bundle branch block, where you get that wave of electric from one to the other. That myelin sheath keeps it from jumping. Synapses are the spaces in between. Go ahead. It's an overstimulation of the nerves. So if you think of VTAC or VFib, it's kind of similar to that, where you have this nerve just flipping out and it's sending like way too many transmissions, where the brain starts to go, this isn't right, and then you get the motor response. It's like a hard reset. It's like a Control-Alt-Delete for the brain is what a seizure is, because of the out of control impulses. So acetylcholine is the traditional neurotransmitter in most nerve synapses. Okay, so that's what brings travels or transports the stimulation from one nerve to the other. And here's a tiny little picture. How adorable. That's kind of what a synapse looks like, is I guess how we imagine it as people who can't see things that tiny. We're not going to focus on how that works. Reflexes are, you don't think about, right? I think we've all had our reflexes checked at the doctor at one point or another. Basically, it's the nerve is reacting without conscious thought because it is a protective measure. There's a certain set of stimulation that causes your nerves to react by themselves. Something like touching a hot stove, right? So now you're touching a hot stove, instead of going and being, oh, well, that's quite warm. I think I'm burning my hand. And pulling your hand away, your nerves are like, stupid, that's hot, and pulls it away really fast. It's a very complicated, it's basic in so much as like reptilian brain, but it's complex at the same time, where it does bypass any of that like hardcore thinking that you would otherwise have to do. And patients who have like a neuromuscular disease are not going to have the same reflexes as other people. People who have, again, sodium derangements are not going to have the same ability to have reflexes as you would expect. And they call it, it's either hypokinetic or hyperkinetic, right? So you could have people with really slow reflexes or people with really like over enthusiastic reflexes. So there's the patellar reflex, right? You're getting whacked in. Nothing like getting whacked in the knee when you go to the doctor's office. So your brain is supplied through the carotid arteries and the front and the posterior cerebral arteries in the back. And they surround your brain underneath in the circle of Willis, which is one of my favorite anatomical features of the human body, because I just imagine it's Bruce Willis in there in Die Hard, and he's protecting your brain from, strokes and such. And then you have the veins, right? So that's why the veins coming down from the brain is a JVD, right? The jugular veins, internal and external jugular veins that we have. So your brain has what we call, like, right, it's split into two, and then there's a ventricle in the middle. And the ventricle's split into various positionally named things. And that's in the center of your brain, and that the ventricles produce cerebral spinal fluid. Okay, and it is important that it is full of cerebral spinal fluid. It's not too much, not too little. If you have too much, you end up with hydrocephalus, right? And they have to go in and they put in a shunt to drain some of the extra cerebral spinal fluid because it puts too much pressure on the brain. If you don't have enough, there's another issue, or they try to keep it from draining out too much. And then on top of that, you have the possibility of getting blood inside the ventricles. Once you have like a hemorrhagic issue where there's blood inside the ventricles, it's really not a great outcome. It's very irritating. Blood is very irritating to tissue because of the iron that it holds. So it's usually just not a good outcome. If the ventricles are full of blood, usually that's like a dominoes and biscuits sort of event. I think that's probably the only scenario I would imagine would be where you had unilateral JVD, is if there was a venous occlusion on the other side, because arterially you're going to get blood, even because you have those 4 arteries supplying blood to the brain. So even if you have one of the large vessels that are occluded, it's still going to drain through the veins, so you would still have JVD bilaterally. It would be only if the vein was somehow severed or occluded. The brain does different things in different spots. So the brain stem is your medulla, the pons, and the midbrain. While you have also the cerebellum, the hypothalamus and thalamus, which is in the diencephalon, and then the cerebrum. If we're looking at this fun little picture, you can see here on the bottom you have the cerebellum is the back. And then you have the midbrain, pons, and medulla oblongata, right? Everybody, the water boy, great description of what the medulla oblongata does. This is essential, right? So we always talk about, you see the people who try to off themselves by shooting themselves in the head, and they survive because they only took out the front, the frontal lobe of the brain, which, let's see if I don't. So the frontal lobe, right, gives you personality, and a number of other things. Where, like right here is a frontal brain. Whereas if you were going to commit suicide and you wanted to actually be successful, what you have to take out here is the reptilian brain. This part of the brain is what controls your sleep cycle, your heart rate, your respiratory rate, all of those things, which if you have a patient who's experiencing a brain bleed, this is the part that gets pushed out of the hold on. Thank you. I have such a hard time with that word, which I can't see it. So as the brain gets displaced and pushed, and the brainstem is what starts getting pushed out. That's what we consider herniation, right? Is when this brainstem starts dipping and leaving. And when that happens, that's why you have the patients who have the respiratory derangements, right? When they're breathing strange, they're unresponsive. That's because that reptilian brain that controls all those essential functions is what's being crushed. Yes, it is. Beautiful. So like, as I said, right, there's different things that can cause pathologies, neurologic pathologies. Brain tissue, right? If you have a lack of blood to brain tissue, it's going to create a stroke. If you have blood in brain tissue, it's a hemorrhagic stroke. If you have too much CAS, cerebrospinal fluid, then you have hydrocephalus, which can cause all sorts of issues for patients. Right, so there's a lot of different things, but really we primarily kind of deal with strokes and seizures. We also do deal with like chronic illnesses where you'll see patients like maybe having an issue with Parkinson's, or a muscular dystrophy patient, or a paralyzed patient, or something to that effect, where you might have to manage it, but it's not necessarily a new onset for them. We don't really go and measure the intracranial pressure exactly as they do in the hospital, where they drill a hole in a skull and then measure it. The normal range is between 60 and 80, but this is also why you see in Cushing's triad, like Joni had mentioned, this is why you start to see an elevated blood pressure. So when you have herniation, it starts to reduce your blood pressure because you're putting pressure on those structures, and because the brain thinks it's now getting less blood flow, because again, you're putting all that pressure on those structures. And as you reduce blood flow to the brain goes, oh no, we're dying, quickly increase the blood pressure. So it increases the blood pressure, except now you're herniating more, which is decreasing blood flow to the brain, which the brain then goes, oh no, I need more blood, I need more oxygen, give me more. And this is why you have patients who have, as they start herniating and start showing that really bad Cushing's triad, they'll have that decreased heart rate from the herniation, right, the brainstem being crushed, and that really high blood pressure from the brain calling for more oxygen and doing the only compensatory thing it knows how to do, which is increasing the blood pressure, but the blood can't get to the brain even if, the blood pressure is that high. And that this little chart says pretty much the same thing. Also, cerebral blood flow is affected by pH as well as the amount of oxygen in the blood. This is why we have patients, right, who are hypoxic, who are very confused. It might be a little on the hypertensive side, because it's the same thing. The brain's calling for oxygen, so it increases the blood pressure in order to kind of accommodate those needs. Cerebral edema can also do kind of the same thing as increased or hemorrhagic stroke. It's just putting too much pressure on the brain. Think about it. Your brain is inside this really snug case, and then you start adding extra stuff into that really snug case. It's not going to be able to accommodate. It's going to look for an escape, and that escape is ultimately kind of just herniation. Unless there's an open wound, in which case, if you have somebody who has an actual gunshot to the head and they have, an exit wound, or an entrance and an exit wound, you're not going to see Cushing's triad necessarily, because that pressure has a way of escaping. And it's usually, in the back of your ambulance where that's escaping. again, much like every other patient that we deal with on a regular basis, your goals are to maintain the airway, make sure that the patient's being adequately ventilated, that there's any bleeding is controlled, and that you're supporting the cardiovascular system, right? So if your patient is hypotensive, you're going to support that. If your patient is hypertensive, you're going to try to figure out how to fix it, because taking away the compensatory mechanism, low pressure in a patient with Cushing's might be beneficial, right? Where the brain can actually prevent being herniated. Whereas, elevated blood pressure due to another, pathophysiology, taking that blood pressure away might actually do more harm than good. Like, in an MI with erectile dysfunction medications on board. So I kind of remember that this is your main goal, is that you are going to provide high quality care to the patient regardless what their issue is, right? But your job is to also do a high quality patient assessment so that you can determine what is going on, so you don't do something damaging. Because if you walk in and you have a patient who has a blood pressure of 220 over 100 and their altered mental status and their heart rate's 30, and you start pacing them because you think it's cardiac and not that they're, Cushing's triad, that's a problem. Okay, so this is why you need to make sure you take a good patient history, a good history of the present illness, so that you can, in fact, not cause harm. ABCs, I like how we added here, exsanguinating hemorrhages of X. That's new. We're going to confuse your ABCDEs by adding an X in front of it. Vomiting. Okay, vomiting in patients with head injuries it's like they go together like peanut butter and jelly. So if you are in any way, shape, or form concerned that the patient is going to vomit, or they are already vomiting, controlling the airway should be a main priority, right? You might have to call for orders to intubate. You might be able to intubate that patient without sedation, right? It really depends on what their level of consciousness is and what their Glasgow Coma Scale is. Again, right, if you have a patient who is AMS, you might have to do a lot of detective work. You might have to look at medications that they take. You might have to look at the surrounding, environment and see what's going on. If you can't get a history from family or something like that, you might, have to kind of wing it and see what medications they have and build a history from there. Any significant decrease in Glasgow Coma Scale of 3 or more points is a very bad sign. Okay. Some places also say 2 or more points, depending on who you're talking to that day. Very, very bad. It's a very poor prognosis neurologically. Patient might just end up being a veggie. So just, keep that in mind. This is why we do ongoing assessments, right? This is why we make sure that, the patient is still able to talk to you. If they started off being able to talk to you and you get to the hospital and they're a GCS at 3, that's a problem, okay? Unless you're the one who put them out, in which case it's less of a problem. But, that's troublesome. That means that their neurological outcome is going to be poor. Posturing. Let me see if I can put my little window up in here. So, let me stop share for a second. So posturing, right? You have decorticate, where the patient has flexed arms and extended legs. Decerebate is extended arms, extended legs. Decorticate is better than decerebate. Decorticate is I'm holding on to life. Decerebate is it's been real, bro. It's gone. Okay, they're letting go. They're not able to their brain's herniating at a point where they're not going to do well. Let's put it that way. Do well. Yeah, they have like their hold on, I have to stand up. So decorticate, they have their arms in. Decerebate, their arms are out like this. And they usually Your hand's gonna go like that. Yeah, the brainstem. Yeah, the brainstem same piece. Yep. It's not a good day for them. All right, back to Sharon. This boring ass. I don't know why they make their slides so boring. Like, the number one rule of making a PowerPoint presentation is like you don't have this much text. Just sadness. Anyway, so just make sure that you kind of remember that abnormal flexion with abnormal extension is decorticate, because that's usually a test question, while double extension is decerebrate. Okay, just remember those things. Also, if you have a patient who, is unable to move one side of their body unilaterally, right? Usually we suspect a stroke. If they're unable to move one half of their body in a superior inferior aspect, right? You're suspecting a spinal column injury or something similar, and we'll be talking about that in trauma. Not right now. Pupils. Pupils are super, super important, and not enough people check them. So obviously we're all very familiar with pinpoint pupils, right? So pinpoint pupils, the number one thing that we associate pinpoint pupils with are narcotic overdoses. However, they're also associated with what we call a pontine bleed. So a pontine bleed in that pons, in that brainstem, if that starts to kind of start leaking blood, which it pops a valve and it goes, right, and all of a sudden you have a bleed inside that pons area. The patient will present with potentially posturing as well as pinpoint pupils. Okay, and you'll give that patient, they'll also have the respiratory, the slow breathing or irregular breathing, and you'll give them Narcan and it won't do a thing. Okay, and if you have a patient in that situation where you're like, oh, this looks like a narcotics overdose, simple, easy, no problem, right? And you hit them with the Narcan and nothing happens, you should call that in as a stroke. You call that in as a potential pons bleed, or pontine bleed. Yes. So if you have a patient who you have a high suspicion of it being a narcotics overdose, where they have pinpoint pupils and irregular breathing, and then you give them the Narcan and nothing happens, nothing changes at all, their breathing doesn't improve, their pupils don't dilate a little bit, highly, highly suspect that it is going to be a pontine bleed, and you might consider calling in a stroke notification for it. Yes. Yes. Awesome. Mm-hmm. Yeah, which is just really, really cool. I mean, not for the patient, but for seeing that, it's really cool, and you're like, oh, okay, I understand. I know what this is now. Good, that's awesome. Other illicit substances, right? If you have a patient who's taking cocaine, for example, or methamphetamines, they might actually have dilated pupils, right? And certain medications like LSD and Molly can cause dilated pupils as well as a very high body temperature, where the patient can actually burn their brain out, which is just not a good look for anybody. So this is why you really need to check the pupils. Other cool things. Well, I'm going to stop the share for a second. So other cool things that your eyes do is if you have a patient who has a hemorrhagic stroke. Let me take these off. Not that you can. There you go. They will look at where the bleed is. So if you have a patient with a gaze, and when you bring into the hospital, go, oh, the patient has a leftward gaze, that means that they're doing this, and they're looking at where the bleed is, which is just wild. Your brain is just excuse me, over here. The problem is over here. I'm looking at it. Go that way, right? It's trying to fix the problem. That it's just weird. It's just wild. Other good telltale signs of a patient who has a potential brain bleed is a blown pupil, right? So you have one that's reactive to light and kind of normal. The other one's going to be like just blown and dilated and not really responsive to light. If you have those unequal pupils, again, very, very strong, strong possibility that the patient is having a bad bleed, okay? And yes, the brain is absolutely going, hold on, playa. Answer. Yes. However, the optic nerve does not cross. The optic nerve goes straight back. Yeah. Well, so the thing, actually, the optic nerve goes straight back, but it's flipped. Your brain actually flips you're seeing things, and when you see it in your brain, it's upside down, and then your brain flips it back up the right way for you. When it goes, the nerves that come through your spinal cord are flipped. So when you have a patient with left-sided weakness, it's a right-sided stroke. But so while that's contralateral, I'm going to double check on this. The are ipsilateral. Well, because it's not the optic nerve that's causing the blown, it's the oculomotor nerve. Let me double check on that. I'm pretty sure it's on the same side because it's a cranial nerve and not a spinal cord nerve. No? What do you mean pop? Pop like it went, or like... Mm-hmm. That's not fine. Okay. Oh, okay. Because it was deflated, essentially. Okay. Yeah, that's because it sounds like an orbital blowout fracture, and we're going to talk about that in trauma when we get there too. But like the posterior wall of the orbit can fracture and like pop into the eye, which might be what she had done. Yeah. No, it's not that hard, but it has give, so it won't like rupture. Because even if you have some pressure on it, and the number one rule in EMS is all your elderly people will be in the one room that has the furniture with the most pointy sides, without fail. Yeah, I had this lady once. She had the furniture that they had had like 6 corners, and each corner had a point on it, like all the way down, like for drawers. So it was like 6 weird hexagram looking furniture, and then like each drawer had extra corners. I don't know. She must have hit every single corner because her face was just, Evander Holyfielded. It was just not a good look. And the wife, she was in Howard Beach, and the daughter who was on the phone was like having a conniption that we wouldn't bring her to Manhasset during rush hour. We brought her to Jamaica, and her, like, she had like a Lafort fracture. Like, her whole face was just, yeah. I was like, well, maybe you should put some foam on this. Pool noodles, everyone. Pool noodles to protect your elderly. No problem. It's good. Back to share screen. All right, so we talked about that, the ocular motor nerve. Extraocular movements, again, is a cranial nerve. Patients should be able to move their eyeballs in 6 directions without moving their head, right? So you have them follow your finger like you're making a letter H. Like, if anyone's ever gone to the eye doctor and they go, all right, follow my finger, like they go left, right, up, down, side to side, that they should be able to do that. If they can't move their eye in one direction, it could be a sign of a stroke. That gaze deviation that we talked about a little bit while ago, right? Very strong sign of a stroke. If you have a patient who's had some sort of head trauma, like Rob's chick, and she's unable to move her eye in a certain direction, the muscle might actually be impinged inside of a piece of broken bone. Which is also the eye is held in place by three small muscles and the optic nerve. Anyone see the movie Hostel, and like her eyeballs popped out and like kind of just hanging after her face gets all burned? She could still move the eye because it was still attached to some of the muscles. Right? She could still see, though it's giving probably a little bit of like a weird brain situation because your brain's trying to put together the picture of the world, but like it's looking weird and down. So if you have a patient who's unable to move their eyes appropriately, it might be trauma, it might be a stroke. So we consider coma to be more or less on the same basis as unresponsive to painful stimulus, okay, on the AFPU scale. It could be caused by a number of different things. It could be caused by lesions on the brain. It could be caused by a brain bleed, cancer, tumors, metabolic states, toxic ingestions. This is your job to figure it out, right? It's your job to determine why the patient is unresponsive and if there's any way for you to fix it. Oh, that's so tiny. So 6 general causes of coma: structural, such as intracranial bleeding, head trauma, or brain tumor; metabolic systems, where anoxia, hypoglycemia, DKA, vitamin B12 deficiency, thiamine deficiency, kidney or liver failure, the postictal phase of a seizure; toxidromes, such as anticholinergic or cholinergic problems; opiates, hallucinogenics, sedative hypnotic overdoses, sympathomimetic overdoses; cardiovascular issues such as shock, stroke, dysrhythmias, hypertensive encephalopathy, respiratory problems such as COPD, right, causing, or toxic inhalation, where you have maybe some level like hypoxic syndrome going on, or infections such as meningitis, sepsis, or like a brain abscess. Okay, a number of different things that can cause coma or unresponsiveness. Other fun mnemonics that we like to give you: AEIOU tips: alcohol, epilepsy, endocrine and electrolytes, insulin, opiates, uremia/kidney failure, trauma, low temperature, infection, poison or psychogenic causes such as like if the person's in a psychological catatonic state, shock, stroke, seizure, syncope, lots of S's. This is essentially your H's and T's for unresponsiveness or altered mental status, okay? You can also kind of use your H's and T's for the same thing. It's just kind of called something else slightly different, right? Hypovolemia would be shock. Hypoxia. All of those fit. So if you're having a hard time with AEIOU tips, also remember, go back to your H's and T's. There's a lot of overlap. It does miss some of the things such as epilepsy, kidney failure, right? Liver failure is also another one. If you have a patient who has liver failure, they could have very high levels of ammonia in their blood. And when they have high levels of ammonia, they can present something very similar to a stroke, where they might have slurred speech and weakness. They might have an odor of ammonia. Those of you with functioning noses would have to tell me if they do or not. So yeah, just something to keep in mind that's not on this list. I think ammonia should be added to your A's there if you want to add those in. So if it's a structural issue, right, like a brain bleed or something to that effect, it is more likely to be asymmetrical versus like a toxic issue where the whole body is affected, or a metabolic issue, the whole body is affected. If you have a patient who has equal pupil response, even if it's sluggish, it's more likely it's going to be toxic or metabolic versus a structural issue where, there's a progressive asymmetrical pattern. But quick side note on that, you can have a patient who is having asymmetrical spinal problems, depending on where and how they are injured, if it's involving the spinal cord. Sometimes even if it's how do I say this? If the spinal cord starts to swell based on like blunt trauma or something to that effect, it might only affect one side, or one side faster than the other, just depending on like the way that the swelling is occurring. If you have a patient who's been stabbed in the spinal cord more on one side rather than the other, again, you're going to have varying presentations of that. Even though it is centrally located, it could still present asymmetrically. So just keep that in mind, especially when we get to trauma. There's a whole section on it, and we'll talk about that again. Much like everything else, assess and manage as required, right? If the patient's not breathing well, you breathe for them. If the patient's bleeding, you stop it. Nothing really changes from your immediate management and assessment of the patient. The most important thing, though, that you really do need to do with any sort of neurological issue is to make sure that you're ruling out the metabolic issues. So if you have a patient who is AMS, you're going to want to check a blood sugar, right? If you have, the ability to do cardiac monitoring, you're going to do that. You want to rule everything out to make sure that you're getting the correct diagnosis. So being thorough in your patient care assessment, as well as the history taking, is the priority. So there are two types of stroke. It is either an ischemic stroke, where there's a potential, usually an occlusion of a vein, of an artery. And then there is a hemorrhagic stroke, where one of those veins or arteries bursts. Most of the time, it is an ischemic stroke. There are some stroke risk factors that are modifiable, such as smoking. There are others that are non-modifiable, such as AFib, right? Though, to some point, you can modify your AFib risk by taking your prescribed medications to control heart rate, right? So patients who have AFib who are doing a poor job of being compliant with their medications, don't modify that risk. Other stroke factors can be something as silly as varicose veins, okay, right? That stagnant blood can cause clots that can now be transported throughout the body. Your brain doesn't do collateral circulation the way that your heart does. So if you have an occlusion, the part of the brain that's being supplied by that blood will be killed, right? And time is muscle. You have about 3 or 4 hours to correct the ischemia before those nerves die. The heart has a little bit more time because it's muscle and not nerves, okay? This is why, they sometimes will, if they're uncertain if a patient is having a STEMI or having a cardiac event, they'll track troponins over a number of hours, up to a day, to determine if they're going to stent them or just treat them with medication. You don't have that sort of leeway with the brain. And this is why it is essential for us as healthcare providers and pre-hospital care providers to be able to distinguish a patient having a stroke. And we all like, oh, he's stroking out, right? You can walk in and be like, that's not good. Like, you'll see it. But there's sometimes when it's a little more subtle, okay? I had a guy once, he was living in a 55 and older community. He had a single car accident where he had driven into a parked car. We got there and he's in the nurse's office. They're out of the car, very minor damage to the car. Now I'm talking to him. I'm like, what happened? He goes, I don't know. I just don't remember. I was driving and then I kind of blacked out and I don't remember. I'm looking at him and it's December and he is super tan. And I go, wow, you got like a really nice tan. He goes, yeah, I just got back from the Dominican Republic. I was like, interesting. How long is that flight? And he says, oh, it's about four hours. I was like, oh, okay. And as I'm talking to him, he's looking at me. He's making this like confused face. I'm like, what's going on? He's like, pepper banana. And I was like, huh? I'm like, okay. So I hold up a pen. I'm like, what's the name of this? And he goes, flowers. And I was like, oh ho, right? We kind of traditionally think, right, slurred speech, weakness, etc. Sometimes expressive aphasia is the only sign that you're going to get of a stroke. So this guy, as we progress, right, so we're like, all right, listen, you have to go to the hospital. And he's like, now he's really struggling to find words. And because he wanted to RMA. Now he's struggling to find words and deteriorating in front of us neurologically. And I'm like, we have to go. So we were not far from Stony Brook. We rushed him over to Stony Brook, called in the stroke note. He was in the CT and getting TPA within 30 minutes, which is impressive. And they completely saved his neurological function. So this is where using environmental clues and getting a good patient history is absolutely essential, okay? If this dude was like darker skinned where you wouldn't necessarily notice he had a tan, or he wore a lot of sunblock while he was in the DR, I wouldn't necessarily put those together, but it taken me a little longer to get to that conclusion that he might have thrown a clot while he was sitting for an extended period of time. But, that expressive aphasia is small, very subtle clues that sometimes you're going to have to play detective to pick up. So we talked about this already. The ischemic strokes are one of the number one type of stroke that we see. Usually it could be caused similar to how a heart attack is caused, where there's plaques in the brain and it starts to, it clots up. Or it could be from a thrombus moving around, or an embolism moving around, from AFib or something to that effect. The most important thing is to determine when the patient's last known well time is. Ischemic strokes can happen while people are sleeping and they wake up and they're unable to move one side of their body, right? So you need to make sure that you get a good last known well time, because if you don't, they won't necessarily be able to treat the patient. The other type of stroke are hemorrhagic strokes. It's a leak, right? Something is leaking somewhere. It could be traumatic. It could be spontaneous. This is really what we're seeing in that Cushing's, right? You'll see more Cushing's-like symptoms. Patients who have untreated or uncontrolled hypertension are at high risk. You can have patients who are very young who have hemorrhagic strokes due to AV malformations, okay? And they might just be perfectly fine and then drop dead, okay? Because that connection in the vasculature of the brain, where it usually goes from artery to arterioles to capillary bed to venules to veins, right? So it goes from high pressure to low pressure, isn't there. So it's going from high pressure and artery right to a vein, and it creates like an aneurysm and it just bursts. And it's often many times the number one reason that young people have strokes are AV malformations. And they're not really monitored for, they're not really screened, so it could happen without any warning or any known history of the issue. This is super tiny. Nothing really too wild in there that you really need to know. The other type of stroke or stroke-like issue that we see is a TIA, or a transient ischemic attack. Usually, if a patient has a TIA, they will have a stroke within 3 months. Okay, so these are one of those things where that patient really should go to the hospital to follow up to make sure that, they aren't going to have something happening right away, or there's not a stroke brewing. Usually the symptoms are very similar to an ischemic stroke, right, where you have the one-sided unilateral weakness, facial droop, slurred speech. You could have expressive aphasia, but the symptoms go away within 12 to 24 hours. I don't know why people would wait for 24 hours or even 12 hours for that matter to see if that weakness goes away. Most people hopefully will call 911 because we recognize the signs of a stroke. TIAs also can be indicative of a stroke shower. Okay, which sounds ridiculous, right? But this is just like a wave of clots going up to the brain caused by a number of other issues. It could be sepsis. It could be DIC, disseminated intravascular coagulation. But there's just essentially a spray of clots that cause a lot of damage to the brain. We are in charge of figuring out what's going on, what's the normal state, and when was the last time they were in that normal state. The 8 Ds. 8 Ds are too many Ds. Detection, dispatch, delivery, door, data, decision, drugs, and disposition. We really are in charge of the delivery and door part. Someone else usually has to detect and call 911. Often we don't dispatch ourselves. We are in charge of, as I said, that middle port where we go and we respond rapidly. We confirm that the detection was correct and we get them to the door with an appropriate note. After that, it's in the hands of the hospital. They are the ones who do a CT and determine what they're going to do. We have moved in the city to the SLAMS score, which is the Los Angeles pre-hospital stroke screen with an addition of speech. So it's arm drift. Hold on, SLAMS. So it's slurred speech, arm drift. I've skipped L because I've forgotten what it is right now. Motor, sensory issues, right? It's very similar to the pre-hospital stroke scale. It's more, computer's having a fit. It's more precise and sensitive to distinguishing large vessel occlusions than the Cincinnati pre-hospital stroke scale, which we've previously used. Large vessel occlusions require the patients to be transported to a comprehensive stroke hospital. A comprehensive stroke hospital is able to go and pull the clot out. Sort of like how most of the time comprehensive stroke hospitals are STEMI centers as well, because they have the same kind of capabilities where they go up through the leg and go into the vessels. And they do it under fluoroscopy so they can kind of see where the occlusion is. But they also, instead of putting in a balloon and like smushing the clot into the sides of the vein or the artery, they actually grab the clot and pull it out. Again, manage. So when you get to the hospital, the patient's either going to receive fibrinolytic therapy, which is also TPA, or they will receive the large vessel occlusion treatment, where they go in and they retrieve the clot. Issue with fibrinolytic therapy is that every hole that you've put in that patient will now leak blood. Okay, so if you went and tried to get an IV on this patient and you tried 4 different times and you stuck them full of 18 gauge sized holes, when they give them the fibrinolytic therapy, they're gonna leak, right? They're gonna bleed from those spots. It busts all of the clots, not just the ones that are the ones causing issues. So it's important for you, if you think that the patient's going to be receiving TPA, that you don't try too hard for an IV. Okay, if it's a difficult stick, just bring them to the hospital. All right, seizures. So we talked about this already a little bit, but a seizure is like the Control-Alt-Delete hard restart of the brain when a group of neurons kind of have a little bit of an abnormal electrical fit. Okay, not really well understood yet, but there's a lot of different types of seizures. They can be from full tonic-clonic seizures to small focal seizures. Sometimes patients don't know that they even have a seizure. Patients after a brain bleed, traumatic or atraumatic, are put usually on Keppra or other maintenance drugs for seizures to make sure that they don't have a seizure, because that lesion caused by the blood can create this abnormal electrical activity that can cause seizures. Very common. It's also very common if you have a patient who has some sort of severe head trauma for them to be seizing. Hypoglycemic patients also their blood sugar can get so low that they start seizing. A lot of times you just need to manage the seizure before you're able to do a full patient workup, okay? And we use midazolam for that, or as we like to say, midazold. We, stop the seizure activity, hopefully, and then with the midazolam, and then look for the underlying cause, if any. If you have an ability to get a history of the patient, it's also important to determine if the seizure is like their normal seizure or if it's new or different, okay? Because if it's new or different, it could indicate that there's a metabolic derangement, or there's a tumor or an abscess or hypoxia or something else going on to cause a different presentation of the seizure. Or it could be that their seizure or epileptic disease is progressing. So it's important for you to kind of get a good history there as well. Eclampsia is a kind of special category of seizures where you only will see eclampsia in a pregnant woman. Okay, the only treatment for eclampsia, definitive treatment, is to deliver the baby. Patient can become eclamptic up to 3 months after having a baby. Okay, so if she's postpartum and she's having new onset seizures, it's possible and a good possibility that it's due to eclampsia. Patients who are eclamptic will often, prior to having the seizure, will complain of upper abdominal pain. They will have visual disturbances, and they'll have extremely high blood pressure. Okay, other indicators of a patient who is eclamptic is that they have had a positive protein in the urine test, or a protein urinalysis. Okay, these are all kind of questions that you would have to ask, and we'll talk about that more when we get to special populations, because pregnancy is a very scary and dangerous time for a woman, because there's just so much going on in her body and a lot of things that can kind of go sideways. But here, what's that? Mm-hmm. Okay. Yeah, no, I've had one eclamptic patient ever, and we got there and she was seizing so badly, we actually hit her with a midazolam, because in the city they make you, they require you to call. So eclampsia is not managed the same way that other seizures are. You're actually supposed to give the patient like very large doses of magnesium. So the problem with that is, in the city they make you call and get permission. So by the time you call and say, listen, I have an eclamptic patient, I need orders for magnesium. Okay, hold on, let me get the doctor. And by the time you get there, the patient's been seizing for how long does it take you to get there? 7 minutes, right? So they call, so maybe 10 to 15 minutes that the patient's been seizing. They can manage the baby when they deliver him via emergency C-section if the midazolam even gets to them, because at 10 milligrams to sedate mom, as per physicians I have spoken to, that's not really enough to affect the baby. And even if it is, they will be able to manage it in the hospital after the C-section. But magnesium is the amount of the medication that you're supposed to give. We also, in the city, only give 2 grams of magnesium. The hospital will pump that woman full of like 8 grams. That's a crap load of magnesium. So that 2 grams may or may not touch that seizure. Okay, it might not touch, prevent it or make it, stop. So the biggest issue is that you need to make sure that that patient is well ventilated. You might need to intubate that woman, because now you're not just caring for her, you also need to make sure that that baby's being well oxygenated. Otherwise, it's not gonna make a difference. All right, so focal seizures are a little different because they may or may not actually have like full motor issues. It might be like a little twitch of the hand that comes and goes. It might be like the weakness in the leg, or it might just be that the patient just stops talking for a second, zones out, and then comes back in. That's usually what happens with little kids who are diagnosed with like focal seizures, is that they'll be like running and playing and then they just stop and freeze and they don't do anything. Kids who are in school and are like accused of not paying attention or daydreaming, a lot of the times they'll do an assessment and those kids are actually having focal seizures. So just things to think about. I had a lady once in a dementia unit. She was a trip and fall. And you got there and she was like just rambling away. She was like just making no sense, but like la 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 la, like just talking and talking, and then she just stopped, stared off into the distance for like 15 seconds, and then picked right back up. And I was looking at my partner, I was like, do you think that was a focal seizure? He goes, it might have been. I'm like, do you think that might have been why she fell? Right? She was in the middle of walking with her little walker and she had a focal seizure, just poof, right on her face. So, things to keep in mind when you're doing your patient assessment, because sometimes things are hidden, right? Sometimes it's not as obvious as you would think. Motor onset seizures could also affect, it could kind of do like that transition up. So like it might start in like a finger and then start to kind of go up the arm. So like there's no control in that arm, or they're like weak or shaking in just one arm. Which is different than your general onset seizures where the entire body is involved. It could be an absence seizure. It could be tonic-clonic, where the really dramatic tightening and loosening of the muscles that we see, right? When they traditionally portray what a seizure looks like on movies and stuff, where the patient's really moving back and forth in an uncontrollable fashion. The biggest risk for those seizures is the airway, right? Because a lot of times patients will chomp on their tongue, so you might have some blood in the airway, and the patient who is seizing is not breathing adequately, okay? Let's keep that in mind. If the patient is seizing, they're not breathing appropriately. Good. All right, so that don't work. 1. 2, I hope she cleaned it off first. That's disgusting. 3, at least it wasn't a thumb. I had a guy with his whole thumb in his son's mouth while the son was having a tonic-clonic seizure. And I was like, what are you doing? Get your finger out of his mouth. No, I'm keeping his tongue out of his airway. I'm like, you're going to lose your thumb. And then your thumb is going to go down his airway. And now we have a bigger situation. Get your hand at his mouth. Yeah, I don't know. Wild. So, yeah, good, very good note. You might find patients with weird stuff in their mouth after a seizure. Don't do it. It's not a good look, okay? If you find a patient who is postictal or having a seizure and there's something in their mouth, please remove it, because the airway is very important. Jesus. So one of the things that you really would have to potentially distinguish the difference of is, was it a syncopal episode or was it a seizure? So a syncopal episode, usually the patient will regain, ANO3 kind of right away, once the blood flow is returned to their head, right? So maybe they, stood up too fast, had a vagovasal episode, they, passed out. When they hit the floor and the blood kind of evened out a little bit, they became ANO3 again. A patient who's had a seizure doesn't always do that. Most of the time, they can become very combative afterwards, or very confused. And it takes them a little while to kind of reboot, if you think of your brain as like a computer. It takes them a little while to reboot. So you might have a patient who, for example, is English speaking, but their first language is German, and they're screaming very angry German words at you when you arrive. Totally normal for patients who may have had a seizure. What else? The BLS test question. You have a patient who is experiencing a seizure. What are you going to do? First, protect them. Thank you. Make sure there's no furniture around that they may hurt themselves. There's nothing where they might fall downstairs or, roll into a fire or something. Don't restrain them because you're going to probably potentially break a bone. Make sure a postictal patient doesn't wander because they tend to do that if they're an ambulatory postictal patient. Recovery position is useful, etc., etc. So, what we are concerned about in the pre-hospital care world is stat-ep, okay? It is, the seizure is not terminated, or you're having multiple back-to-back-to-back tonic-clonic seizures, okay? Here they define it as 4 to 5 minutes or longer. Other books will define it as potentially longer or shorter, depending. If you have, I think it's 3 seizures with no real postictal phase in between, or no return to normal mental status, and the patient just goes right back into another seizure, that's also considered stat-ep. This is a patient who absolutely positively needs to have midazolam on board, okay? Or needs to have some sort of sedation to stop the seizure, okay? Because remember, if you're seizing, you're not breathing. Oxygenation is key. Always be prepared for respiratory depression, especially if you're giving a patient, any sort of sedation. Headaches. I'm confident that everyone's had a quote-unquote ridiculous headache call. There's a number of different headaches. We have tension headaches, migraine headaches, cluster headaches. There are some patients or people in the world who have never had a headache. If you have a patient who, and it sounds really weird, but like this, I guess, is up there with like people who don't have an inner monologue. One of the questions you should ask if you have a patient calling for a headache is, do you often get headaches? Because if they get headaches or they don't get headaches and all of a sudden they're getting a headache, that could be a problem. I'm pretty confident that everybody in this class has had a tension headache in the last week. That's basically caused by stress, and either tightening in the muscles from like the clavicles up can cause a tension headache. Migraines are a little bit different because not only does it include a headache, but it can also include GI symptoms such as diarrhea, nausea, and vomiting. Migraines can also mimic a stroke. So where a headache is usually caused by muscles or like a constriction of the blood vessels, a migraine is the dilation of blood vessels usually. It's caused by an imbalance of serotonin or other hormones. So like women who get migraines around their period, it's probably tied to their menstrual cycle. But the serotonin imbalance is what causes the secondary issues with the GI symptoms, especially the nausea and vomiting, because the serotonin area of your brain is in charge of like the whole vomiting process. So you aren't really going to be able to do anything for a migraine. A patient, if they are experiencing really bad GI symptoms, even if they've taken their migraine medication, might not be able to keep the medication down or absorb the medication due to the GI involvement. Sinus headaches, I think everyone knows what that is, right? You get a little pressure in the front of your face. Weakness and fatigue, okay? Weakness and fatigue is one of those things that you will need to do a full workup for that patient, right? So is that weakness due to a neurological issue where maybe there's a stroke, or is it due to a cardiac issue, right? Are they having a STEMI? Are they dehydrated? Did they take too much of their medication, right? Their blood pressure medication? So you need to make sure that you're doing a very thorough history on these patients, because those kind of vague, diffuse complaints are the ones that require the most attention. Most infections will kind of be paired with a fever of some sort. Sometimes they don't. But the meningitis is kind of that young children and college-age children, right? But the hallmark sign of meningitis is quote-unquote nuchal rigidity, which is, let me give you a visual. So nuchal rigidity is that stiffness in the neck. The patient will not be able to put their chin on their chest, okay? And that's, of course, without having any other sort of issues, such as, like, I don't know, a halo, right? Those little, cervical spine jobbies that keep your whole neck aligned, or any other pre-existing issue, right? So if the patient can't put their neck to their chin, that's troublesome. It's usually a good sign that the patient may be dealing with meningitis. Put a mask. Meningitis is extremely contagious, okay? Masks for everybody at this point, as Matt Levin sits in his house with a mask on. All right, back to this. Encephalitis can cause a lot of AMS as well, so you might have a patient who has like a fever and is just like really like wildly out there in terms of AMS, confused, might have some sort of like headache, right? Encephalitis is a inflammation of the brain, where meningitis is an inflammation of the meninges, which is the bit that wraps around the brain as well as the spinal cord. A lot of the times it's just a lot of this mimics influenza or COVID, if you really want to think of it that way. Brain abscesses kind of can present as a stroke-like symptoms as well, but usually it's a slower onset. The nasal cavity is like probably the number one origin of brain abscesses, just because it's location. So big old accumulation of purulent material. Moving on. Tumors. Sometimes a patient doesn't know if they have a brain tumor. Sometimes they do. Fun story. I'm gonna stop sharing again. Had this guy once. They called for seizures. Guy's full-blown stat app. Okay, he's been seizing now for probably 10-15 minutes before we got there. Okay, so 10-15 minutes before they even called. Another 5 minutes for us to get there. So 25 minutes of seizing, right? So we're like, oh, that's a lot of seizing. So we hit him with 10 of Versed. Doesn't stop seizing. We're like, well, shit. Okay. Call medical control. Hey, we can't get a line on the guy. He's full-blown tonic-clonic seizing. Can we give him more Versed? They're like, yeah, hit him with another 10. Hit him with another 10 of Versed. Still seizing. The wife is standing there holding this piece of paper like this. Ma'am, like, what's his medical history? Oh, no, I don't know, nothing. Does he take medications? No. No, he doesn't. Okay, like, any allergies to food medication? No. All right, cool. Cool chick, whatever. Call back medical control. Finally got an IV. Hey, listen, he's still seizing. All right, just give him 10 of the diazepam if he's still seizing. I'm like, okie dokie. I'm like, can you call in a note, like, let Jamaica know we're on the way? So this dude now has 10 milligrams of Versed, 10 milligrams of diazepam in his system, and he's still seizing. Like, full, like, tonic-clonic, going to town, getting a full-body workout out of this seizure. Get him to the hospital, and they hit him with succinylcholine and rock to knock him out and tube him. And they do, and his stomach is still going and seizing. I'm like, you fully paralyzed this dude. His abs are still trying to work out all on their own. This is crazy. And this is, of course, when the wife shows up, because she didn't want to come with us in the ambulance. She shows up with the same piece of paper. He's a DNI. I'm like, he had a brain tumor. And she's cussing up a storm. This little tiny, like, Guyanese lady cussing up a storm. Oh, he's a DNI. How dare you touch him? I'm like, chick, we were on scene for like 30 minutes. We could have like alleviated this whole situation if you spoke up for like the 15, 20 minutes you standing there with his DNR and DNI. I didn't bring my x-ray vision with me. I'm sorry. So, I can't. People kill me. People really do kill me. All right, back to this nonsense. I really dislike these slides. I apologize. All right, so that's your lecture on brain tumors. No one cares. Patient can have headaches, seizures, etc. So patient might have a brain tumor, might be on Keppra and other seizure medications. Just FYI, not every patient who is on seizure medication is because they have seizures. So make sure you get good clarification. Not much you're going to do for this patient's tumor except for manage the symptoms. Okay, dementia. Dementia versus delirium is a huge thing we talk about all the time. Dementia is a slow progressive loss of awareness, time, and place, right? You start losing memories. They have a hard time learning new things. Most of the time, they will keep their long-term memories, but like recent memories, hard time. So they might recognize their grandchildren, but they won't necessarily remember their names or vice versa. But sometimes dementia patients will have like outbursts because they get frustrated. And I think that we don't appreciate that fact well enough that, every once in a while, if you were forgetful, like think of the last time you walked into the kitchen, opened the fridge, and were like, why am I here? Think about that happening every single day for every single task that you're trying to accomplish. It's very frustrating. So the difference between dementia and delirium is a sudden onset of like a mental status change. A dementia patient can have delirium, okay? It's very frequently seen as like sundowning, right? So like all of a sudden they're like extra confused. But they can also have it like on a Tuesday, right? So they might just be like putzing along, like no worries, having a great day, can't remember my name, think I have socks on, and then they're just even more confused, okay? Like that sudden mental status change that may or may not be permanent, because sometimes dementia does not progress 100% predictably. Just keep that in mind. The difference between dementia and Alzheimer's is that Alzheimer's puts down what they believe that it's due to like protein deposits on the nerves caused by improper glutamate metabolism. A number of other issues. They don't know really what the issue is, which means that they really don't know how to fix it. Early signs is usually. Go ahead. Yes. 100%. I don't know who spelt this, but Huntington disease is spelt like the city in Long Island. I don't know what Huntingdon is. Huntington's disease is a genetic issue that causes degeneration of the neurons in the brain. Very similar to Parkinson's, but much more rare. Again, uncontrolled movements, difficulty walking, etc., etc. I don't know why Parkinson's isn't in this, but Parkinson's is also a neurological disease that's caused by a lack of dopamine production. So often to treat Parkinson's disease, hold on, I'm going to stop the share for a second. Hey, I have a face. Often to treat Parkinson's disease, they'll give the patient a medication called carbidopa-levodopa. Okay? The blood-brain barrier does not allow dopamine to transfer across the blood-brain barrier, okay? It's protective. It keeps the brain kind of sealed and safe. Carbidopa levodopa can, and then when it gets into the brain, it's metabolized into dopamine to help alleviate some of the symptoms. The problem with carbidopa levodopa, which is really fun to say, it can cause severe hallucinations. Severe, okay? And Parkinson's as it's on its own can cause hallucinations. Now you're combining it with this other medication that's supposed to give them relief of their shaking, and it causes the same problems. So just keep that in mind. Another fun fact, so one of the hallmark signs of dopamine, or two of them, because one of them is really interesting, is the flat affect. So look at a picture of Michael J. Fox from like the last 5 years. That flat affect that he has is due to Parkinson's, okay? Dopamine is a fine neurocontrol neurotransmitter. So like those little tiny muscles you can't control without dopamine, and one of the places that you see it first is in the face, okay? Because you can't like do the eyebrows. It's like having all over Botox. The other thing is called pill rolling, and the patient's doing this, okay? This is often one of the first subtle signs of Parkinson's is they'll be doing this with their hand and not even notice it. This happens before the tremors set in, okay? So they'll go from like this to like this, right? Just because a patient has tremors does not necessarily mean that they have Parkinson's disease. If you look at Ozzy Osbourne, he has Parkinsonian syndrome, which is where he has a bit of a tremor, but it's not actually Parkinson's. It's probably just due to like super drug use. Yeah, so that's my Parkinson's spiel, because apparently it's not that important in this. We're going to cover the super rare Huntington's disease, but not Parkinson's. If you would like to know more about Huntington's disease, 13 from House had Huntington's disease. There's your lecture on that. Moving on. That's not the right screen. All right. Moving on. Muscular dystrophy. Okay, also relatively rare. Most of the time it shows up in younger children, okay? It is a slow progressive degeneration of muscle fibers. It could also be caused by a neurological issue, right? Where the neurological impulses to the muscles are also affected. Most of the time patients die from pneumonia or respiratory failure or heart failure, depending on how it progresses. Duchenne's muscular dystrophy is like one of the more popular ones, and it primarily, almost all muscular dystrophies are exclusively a Y chromosome only. There are some girls who do have muscular dystrophy, but it is most commonly seen in boys. MS, okay, is a demyelinating disorder, okay? Numbness, tingling, paralysis, incontinence. It can have flare-ups as opposed to being progressive. There's a lot of medication treatments that can kind of either slow or stop, slow the progression or stop flare-ups. It's an autoimmune disease, and it attacks that myelin sheath, which causes all sorts of issues. Visual issues are also a huge problem with patients who have MS because it damages the myelin sheath of the optic nerve, so they'll have central vision loss. Guillain-Barré. Ah, yes. The most fun of the French diseases. It comes with a baguette. So Guillain-Barré is an ascending paralysis that's usually caused secondary to an infection or like a vaccination booster, or it's pretty rare. It doesn't happen all that often. But the problem with Guillain-Barré, as I said, it's ascending. So it may stop at like your knees, or it might go all the way up to your diaphragm, and all of a sudden you're trached and vented because you can't breathe. The good news about Guillain-Barré is it often will recede, and it's like nothing ever happened. You may lose a few months to a year or two of your life because you're now bedbound because of this random paralysis. But yeah, that's also a really good one that's not in these slides. Stupid. Let's see, peripheral neuropathies, diabetics, like primarily diabetics are the people who have peripheral neuropathies. Plenty of other people have them as well, but diabetics you're really going to see it the most because they like will stub their toe and not feel it, and then their toe becomes gangrenous and falls off, or they become septic from it. Aha, Guillain-Barré. Most of the time, they think it does have an autoimmune component. It is the hallmark is that it is an ascending paralysis. So if they're like, oh, you have a patient who is, has an ascending paralysis, what would you suspect? It's always Guillain-Barré. Okay. Dystonia. Dystonia is one of my favorites. So let me stop this. Dystonia is great. Usually associated with psychotropic drugs. So anything that's used to kind of control schizophrenia or bipolar or any other like really serious like kind of psychological concerns. They're not really sure what happens, but all of a sudden the body will just like kind of rigid up. Had a lady once. She was sitting. Her ass was on the seat, on the edge of the seat, and her back was on the kitchen table, and she's like doing like this crazy back bend, and she's completely stiff. Like she was we picked her up and she was still kind of doing like a Thriller move across over to the stretcher. So, her friend is like, she had a seizure. And I'm like, but her eyes are still moving. Like if you talk to her, she'd look at you. So I'm like, all right, so it's not a seizure. Like, I'm really confused. So then she did have a seizure. So we hit her with midazolam. She did not get any like less stiff. So I'm sitting there and I'm like, all right. And then she stopped breathing. I'm like, what the hell? What's going on? So I'm paying my head medic student ventilating the patient. And I'm like, if she's got a history of seizures, maybe like, so we're like flipping through her bag and we found psychotropic drugs. I'm like, this must be dystonic reaction. My partner's like, how what? And I'm like, don't worry about it. I call medical control. I'm like, hey, listen, I have this patient. I'm pretty sure she's having a dystonic reaction. I'd like to give her 50 of Benadryl. But I can't get, like, I have no veins on her. Haldol. Haldol is one of the most common drugs that cause dystonic reactions. He goes, all right, give her 50 of Benadryl. I am. Cool. Give her 50 of Benadryl. My medic student has the blade in her mouth, and he's about to pass the tube, and she goes, sits up, and was like, what happened? And I was like, my medic student was so pissed. He's like, I was going to get the tube. Priorities. Remember, when you're a medic student, your priority is always the tube. So dystonic reactions are pretty wild. Benadryl is your cure. Really, like, literally can just pop up out of nowhere, most of the time associated with Haldol or other psychotropic drugs. And there's my TED talk for the day. Parkinson's disease can also cause dystonia. Dystonia is a little different because it's a movement disorder where it's like really rigid movement, but dystonic reactions are caused by psychotropic drugs. Cranial nerve disorders. The one I'm going to say that you're going to need to know the most about is Bell palsy. Okay. Traditionally, the longer the seizure, the longer the post-ictal phase. Okay? No problem. So cranial nerve disorders, I want to say that the one that you're going to really deal with the most is Bell's palsy. And Bell's palsy will kind of present like a stroke where you have like the unilateral facial weakness, but the difference is that there won't be any I'm having a little stroke right now. The Bell's palsy won't have any like arm weakness. You'll have like facial drop and speech slurring. Another really cool way to kind of determine the difference between Bell's palsy and a stroke is if they can raise their eyebrows. So a patient with Bell's palsy will be able to raise their eyebrows. A patient who's having a stroke will not. Like pretty solid science backing that one up. So eyebrows will go up if it's Bell's palsy, because this part of the face is not controlled by the seventh cranial nerve. Patients with a stroke will have issues. Okay, moving on. Y'all blowing up the phone right now. ALS, active degeneration of the brain and spinal cord, not really good prognosis. Yeah, okay, cool. Not really much else. We're not going to really talk about ALS. What are we doing for ALS? We're not diagnosing it. Okay, patient says I have ALS. Okay, it's a neurodegenerative disease. Okay, you're going to manage their airway, their breathing, and their circulation. This is a lot of my issue with some of the paramedic curriculum is like, we're going to give you all of this information that you're like, have to know. And like, how are we like managing it differently? So just kind of understand the general gist of it. It's a degenerative neuromuscular disease. Lou Gehrig's. There you go. Any other thoughts or questions before we move on to endocrinology, which is short, I promise you? No? Anyone feeding this baby like alcohol? Is this what this is going on right now? Right on the gums. You don't have to give a binky. Right on the gums. Do not scroll up past this point. Yeah, okay, no, that's definitely gonna scroll then. Is that Bowser? Just saying. I saw it before. It's adorable. Y'all rude. Alright, any actual questions regarding... If you have a tear in the dura of your spine, begin to leak spinal fluid, it can cause herniation in the brain. Yes. Ooh, other side note. And I know because one of the medics, whatchamacallit, at Jamaica had it. It's called, god damn it, I've forgotten the name. It's a malformation of the, say it, Rob, say the word that I can't say the thank you. It's a malformation, Chiari syndrome. It's a malformation of that, so your brain is, like, it's too big. So your brainstem just kind of slowly, like, leaks down. All on its own. It herniates without trauma, which is wild. So they actually have to go in and surgically fix it so your brain stops falling down. So yeah, so random little Chiari